responsibilities. So today we've got an interesting one. Is IJV compression on imaging a big deal or not? And at the end of the day, this is a very common question I get. It seems to really perplex a lot of craniocervical instability patients. I think they get sort of backed into a corner where they're thinking to themselves, do I need to have the IJV surgically decompressed? Should I do that first? What's going on? Some physician told me that I had IJV compression. Does it need a stent, etc.? Should I get surgery to carve out a little bit of the C1 transverse process, etc.? So we're going to get into that today. As usual, we'll start with about 10 minutes or so of just some didactic material going over this topic. And then after that, we'll get into questions and answers. You can ask questions about this or really any other topic. And it's always best to get your questions in early because I answer them in the order they're received. So frequently, I'll get more questions to answer than I've got time to answer them. So if you get them in early, that's good. You submit a question by just typing it into the comments. No matter where you are, whether you're on Facebook or YouTube, it'll be fed to me here. So again, if you're just joining us, we're getting into is IJV compression on imaging a big deal or not? I tend to do these Facebook Lives on these timely topics that I see being discussed on social media, and this is a really big one. This is one that really perplexes a lot of CCI patients. They're very concerned about this, so I wanted to start to cover it. Again, you can ask questions about this or any other topic. You submit a question by entering a comment, and it doesn't matter if you're on YouTube or Facebook, I'll see it here. Realize that I answer those comments in the order in which they're received. So if you submit a comment early or a question early, I'm much more likely to go ahead and get that and to be able to answer it. If you submit it very late, then that can be really hard for me to answer. So let's start this here about IJV compression. So first, like, comment, share, subscribe. That's how people find this information. If you like the idea of a CCI expert who spends his Thursdays or Sundays answering your questions, then pay it forward in the CCI community so that other CCI patients can find this content. So a rule of medicine is really that we do diagnostic tests if we think they're going to change the treatment plan, right? You don't do them just for information. You do them because a diagnostic test might tell you as the doctor whether or not treatment A or treatment B might be better. If you don't think a diagnostic test is going to change the treatment plan, then there's really no reason to do it because diagnostic tests come with certain risks. And certainly when it comes to imaging of the IJV, you've got to usually do a CT scan venogram or CT venogram or CTV or CTA, CT arteriogram. And CT is a lot of radiation exposure. So it's not a good idea to expose the patient to that radiation if you're not convinced that you're going to change the treatment plan. So let's talk a little bit about the IJV and craniocervical instability, or CCI. So the basic concept here is that if the internal jugular vein, which acts as sort of the blood venous outflow for the brain, gets blocked without collaterals, and those are the little veins that grow around the blockage, then that can increase the pressure inside the head, and that can cause symptomatic intracranial hypertension, or sort of this pressure sensation in the head. Can lead to other symptoms as well. And as you can see here, we've got some things going on, right? We've got the IJV there in blue. And if you can see on the side view, the transverse process of C1 in particular, but also C2, is right in front of that, or sorry, right behind the IJV. And then you can see from the front and back view how it all looks. So you could imagine that if you had instability at C1, C2, for example, that could intermittently put pressure on the internal jugular vein. And that's the reason why when you see surgeons who are involved in this space, oftentimes they will take off some of the transverse process of C1, because that's a common area of compression. But you can also see on the side view that the styloid is right in front of the IJV. So that's another reason that you see patients opting for styloidectomies with or without getting the transverse process of C1 cut out. So again, got the styloid right in front there. You can see that pressure coming forward from the C1 transverse process. Concept there is that the IJV is getting compressed between the two structures. And this is kind of what it looks like from a top view. And this is sort of heavily abstracted, but you can see the IJV there, those blue circles. You can see the styloids. You can see the transverse process of C1 right behind the IJV. And you can also see alar ligaments and transverse ligaments there, that if those are loose, that could cause some intermittent compression of that internal jugular vein. And this shows a rotational possibility for rotational instability, where you can see that IJV getting compressed by the transverse process there on one side, whereas the other side opens up more. Now, this is an interesting one. I really like this because it's a beautiful picture. So this basically shows the IJV here, and this is the top part full of contrast, and then the bottom part getting kinked off by the C1 transverse process. So this is just a beautiful venogram that was done by an expert interventional radiologist, showing the IJV opening and closing with head rotation. So I've always loved the art involved, because medicine is science, but it's also an art, and it takes quite a bit of interventional radiology art to produce an image like this. And I actually spoke to the radiologist who did this, and really gave him kudos, because it's very rare that you see these beautifully done studies like this. So that's one side of the imaging coin, right? That we have this idea that you can see decreased flow right at C1 there in instability patients. But it's important to look at things from both sides so that we have a full understanding of what that means or doesn't mean. So one of the things that surprised me many years ago when I first looked into this was I had the question of how common is static IJV compression in patients without symptoms, or at least in patients without the index symptoms that we would expect. Now, you would expect this prevalence here to be very, very low. You would expect it to be very, very rare to see a normal person walking around with IJV compression who didn't have symptoms. And in fact, you really depend on it being very low for any test showing IJV compression to be important. But it turns out that that's not real. So basically here, this is one study. We'll go over 3 different studies that looked at 108 consecutive neck CT arteriograms or angiograms. These were looking for other things. They were actually looking at the internal carotid artery in these patients. And they just recorded an awful lot of people who didn't have any symptoms. A third, 1 in 3, had moderate stenosis, and 1 in 5 approximately had severe stenosis. And they only found about a third of the patients who actually had normal IJVs. So what this study shows is that it's very common to see IJV compression in patients without symptoms. And then we've got study 2 now here. So this is another study that looked at 164 patients. And they were, again, looking for other things, but they found about 15% of the patients who had either an absent IJV or it was very, very, very small. And they found about 1 in 4 patients who had a severely occluded IJV. And the most common area of compression, again, was the C1 transverse process. But these aren't patients that are symptomatic and you're looking for a problem. Study 3 here, 500 consecutive contrast neck CTs. And they found, again, greater than 50% narrowing was about a third of the patients. And again, narrowing occurred most commonly at C1. So lots of people walking around with occluded IJVs. So this is very, very common. So the bottom line is that if you look at the number of people who are walking around who have IJV compression without symptoms, it's pretty high. It's about 1 in 4, all the way up to about 1 in 2, depending on whether or not you consider moderate narrowing included or not included. So then that begs the question, well, if I have IJV compression, and I have head pressure, doesn't that mean for sure that that IJV compression is causing my head pressure? And the answer is no. And that's because head pressure is a very common symptom in CCI. It's due to swollen upper neck joints. It's due to irritated occipital nerves. And it can also be due to intermittent compression of the IJV, where the IJV is getting more compressed with certain movements. So the answer is not really. It certainly increases the index of suspicion that we might be looking at an IJV problem, but you got to treat this other stuff first to see if that goes away, because if it does, it's not the IJV. So if you have IJV compression in a CCI patient with head pressure, what's the next step? Treat that stuff. And preferably treat it without an irreversible surgical procedure. So that would be treat the CCI, whatever that is, whatever type that is, treat the facets and irritated nerves, and then see if it goes away. If it goes away, no harm, no foul. If it doesn't go away, you can always go in and decompress those structures. But as I always say, decompressing those structures also makes the neck more unstable. So we wouldn't want to start there. We also wouldn't want to start with decompressing the IJV, because that's a lot more invasive a procedure than just doing injections. So again, do me a favor, like, comment, share, subscribe so that other people can find this content. That's how the YouTube algorithm works. It allows other patients to find this stuff. Okay, so let's get rid of that for a sec here, and we'll go to starting to answer some questions. JS, I'm going to get a DMX soon to avoid x-ray exposure. Are you still interested in looking at flexion extension, lateral views, and AP open mouth lateral bending as actionable data? Yes. That's a great way to reduce x-ray exposure in a DMX, is to just focus on those parts and pieces. And why that's important is there's other things that are done, right? In the average DMX, You see that. You see oftentimes rotation. You see AP lateral bending without the open mouth. You'll see oblique views with flexion and extension, but we're not using that stuff to get to a CCI diagnosis. So if you want to reduce X-ray exposure in a DMX, the simplest way is just to focus on the views that are going to get information that's actionable. Are you going to use your radiographic ruler to accurately measure distances using the report from another clinic? Is the DMX report going to be useful to you from another clinic? No, the radiographic ruler has to be placed in the field while the image is being done to counteract any magnification effects to get an accurate measurement. Now, there's another way to get an accurate measurement, and that is to control for the exact distance of the patient to the X-ray beam, and for you to have calculated that beforehand and not allow the patient to move from that position. I would say that most good DMX centers do that, so they know how to translate their measurements. Some DMX centers don't do that very well, so their measurements are all over the place and likely inaccurate. And then we put a radiographic ruler in the field so that we know for sure that this amount on the screen is 10 millimeters or whatever it is. So I can't do that after the fact, though. I'm either relying on the measurements from the place that did the DMX because they know what those distances are, or if the DMX is not measured, that's a tragedy because it can never be measured by anybody accurately. Aaron, have you seen CCI present with zero neck pain, but with neurologic symptoms? Have you treated or seen patients with Horner syndrome? We do see CCI present with no or minimal neck pain. That tends to be less common. Have we treated or seen patients with Horner syndrome? Not many, but it's possible. I actually have a video on that topic. So if you go to my YouTube channel and you just type in pupil, it'll probably come up. I've done maybe 2 or 3 videos on how irritation of the cervical sympathetic chain can affect pupil size. Dorcas, I have knees problem and it's bone on bone. What can you do for me to be able to walk without any pain? Well, bone on bone knee osteoarthritis, if we're talking about bone marrow stem cell procedures, that's sort of a sweet spot. But again, I'd have to know a lot more than just what you're writing. Can military neck cause jugular compression? Not usually by itself, but remember, internal jugular vein compression is common in asymptomatic people. So the fact that there's jugular vein compression, and as my father used to say, and a nickel will get you a cup of coffee. I guess in his day, a cup of coffee cost a nickel. Obviously not the case now, more like and if a nickel's $5. But anyway, long story short is no, it usually doesn't. But the fact that there's static jugular compression is usually not all that important. Human being, would tortuosity of the IJV be similar to compression? Generally not. That's a different set of issues. Vera, hello, Dr. C. How many weeks or months post-PICL do you recommend starting the laser clock exercises if they make one symptomatic prior to the procedure? What about neck isometric exercises? Thanks. Vera, there's a whole video series on that, so I would recommend that you go watch that video series. If you just type in rehab on my YouTube channel, that will come up. There's about a dozen of them to go through all that and to help make that decision. You also want to reach out to your attending physician who can help you decide when is a good time to start that stuff. M. Purple. how much does VMC spread from the injection site? For example, if ALL at C2-3 was injected, does it travel to ALL at C3-4? Usually, so ligaments are like a bunch of tight ropes that are bound together, right? And as you might imagine, if you had tight ropes that are bound together, all going in the same direction, that it would be relatively easy to spread in that direction, but difficult to spread against that direction. So for the ALL, going from 2-3 to 3-4, you'd be parallel to the direction of travel of the collagen bundles. So the answer is usually that would happen. M Purple, why don't you inject all asymptomatic arthritic or swollen facets if there's instability? Isn't it a matter of time before they hurt? No, I mean, every medical procedure you have to understand is always risk versus benefit. So that means that we generally don't treat asymptomatic things because there is no expected benefit and there's still risk. So it doesn't make sense to inject all asymptomatic facet joints simply because we're adding risk without adding known benefit. Greg, when do vagus hydrodissection, or when do you do vagus hydrodissection? Do you do them at multiple levels in the cervical spine? I believe I've seen this done about C1-2, but wrote a big article that around C5-6 has also been used. I think you may be confusing vagus nerve hydrodissection with other procedures like stellate ganglion blocks. So stellate ganglion blocks are frequently done in the lower cervical spine, whereas vagus nerve hydrodissection is usually done in the upper cervical spine. Vera, how many weeks after lumbar PRP can we have dextrose prolotherapy on the same area? Well, dextrose prolotherapy works by killing local cells. It's a chemical debridement. So you would want to wait a good several months because you want a full healing cycle to occur before you go in and kill small numbers of cells to cause a brief inflammatory healing reaction, because that's how dextrose prolotherapy works. Alex, is there a structure specifically that causes pressure behind eyes and forehead, way worse when out of alignment? Yeah, Alex, I mentioned some of those, but the common structures would be the upper neck facet joints, the upper cervical bursa, and the occipital nerves can all cause that. So again, those are common symptoms that, for the most part, in most CCI patients, do not come from internal jugular vein compression. They come from those other structures. James Lawrence, how soon do you think Regenexx doctors outside of Colorado will be able to do posterior injections at C0 to C2? That requires a lot of additional training, and until those doctors are willing to come out and give up many weeks of their time in Colorado to be trained, the answer is never, meaning at the end of the day, that's not a see one, do one, teach one, that we have a training program that requires those doctors to take time off and to come out to Colorado and get involved in those injections to see how to do them properly and safely. They also require usually an upgrade of their equipment. So they need not only a fluoroscope, but they need a fluoroscope with digital subtraction angiography, which usually adds about 20 grand or so as an upgraded feature to that fluoroscope. So it's possible to do, but it's very difficult for doctors to take lots of time off outside of their vacations for practical reasons, right? Any moment they're not spending in the clinic outside of the vacation, they're losing money. So when they go to courses, it's like a weekend course in the US. Now in Europe, it's socialized medicine, so not so much. The courses tend to be during the week. But in the United States, without socialized medicine, courses are on the weekends. And this is more than a weekend course. Alex, not holding alignment as long at 15 weeks as I was week 8 to 12. Is there a reason for this? Yeah, Alex, I would need to know some context there. Maybe you're describing that you are now at 15 weeks post. I'm assuming post EPICL, but you'd have to tell me. If that's the case, then that may be a part of the donut hole. A good thing to do would be to go to my YouTube channel and look up donut hole. Tyler, are there long-term studies that would be interesting to see if compression just takes a long time to manifest with symptoms? Tyler, I don't know of any long-term studies that have been done looking for things like Alzheimer's, dementia. I think we have a lot of theories that those two things could be related, but we just don't know at this point. Those are more theories than anything. The strength pill, how do you differentiate if you have ligament laxity or a muscle problem? It's a good question, because at the end of the day, you need both strong ligaments and strong muscles in order to provide stability. So it could be either if you have instability. Now, generally, the way you tell those apart is you have lots of clues, right? You can do a stress test of a joint. So a good example of that would be that DMX, open mouth, lateral bending view, where if it's a muscle problem, you're not going to see excessive motion there, because it's the ligaments that determine motion at the end range, and that's at the end range, so you shouldn't see overhang past a certain point. If it's a muscle problem, you can get clues like muscle atrophy on the MRI that's usually not read out by the reading radiologist, but it's easy to see. So again, muscle problems don't cause excessive motion because that's dependent on the ligaments working. When you do have muscle atrophy, what you tend to see is extra motion in that mid-range where things are moving too much, and that can cause lots of havoc, but you're not seeing extra motion at that end range. Amy, I'm scheduled for a cervical fusion revision this week. I think it'll be C2 to C6. Happy to be here for your live today. Great, Amy. James, do you think there will ever be a time when joint procedures will be covered by Medicare? Maybe at some point in the future. I think that's very, very unlikely anytime soon. Regenx procedures right now are covered by thousands of US corporations that are usually mid-sized to larger corporations. And the next step would probably be from there getting coverage by a single large health insurer. And then from there, it would be multiple large US health insurers. And then from there, it would probably be Medicare, Medicaid, that's sort of the progression of these things. But to be honest with you, I think that's a long time away and no time soon. Robert, I know some older people who were lively, healthy until one day their IJV was greater than 75% included. Did they notice symptoms? This backs up why it's not exactly a major pathology. Patient Facebook fear assumptions. Too many ran to a hacker and got styloidectomy for no reason. Yeah, Robert, I would tend to agree. I think there's a lot of fear mongering on social media about this IJV compression topic. That's the reason why I wanted to cover it, because it's hard in a social media context, right? It's not always accurate information that rises to the top. It's often those screaming the loudest, and the narrative tends to be driven many times more by fear than it's driven by actual good information. So thanks for bringing that up. D07, after having EPICL, how long should you wait to get other joints like low back or hip treated with stem cells or PRP? Well, you're going to have to wait at least 6 to 12 weeks in order to hit that bone marrow site again if you wanted to do bone marrow stem cells for those. If you just wanted to use blood, then you'd have to get a hematocrit check to make sure that's back to normal. But if it is, then there would be no specific restriction if you're treating areas outside of the neck. So those are the things you would want to kind of think about if you were going to get other areas treated at home. Kaylee, how does vascular TOS play into this, and what approach did you take in prioritizing which compression, maybe what approach do you take in prioritizing which compression to address first? Well, Kaylee, a lot of that depends on the context, right? If what we're talking about is thoracic outlet in the context of a neck problem, then thoracic outlet is common with neck problems. Usually the way that's treated is not surgical. It's treated initially with good physical therapy to try to open up the various areas of the thoracic outlet. Then the next thing that's done is to treat the neck. So for instance, if it's craniocervical instability, many times the thoracic outlet goes away once the CCI is treated. Now, is it possible that you could still have recalcitrant vascular thoracic outlet that needs to be decompressed? That's possible, but now we're in the 1 in 100 range. And the problem is that in order to treat that, oftentimes you have to take some of the scalenes out or with the scalenes attached to the first rib. And that means that you're going to destabilize the cervical spine. By destabilizing the cervical spine, if you have a cervical spine problem, you're going to make that much, much worse. So always best not to remove scalenes, not to remove first rib, because those are like the guy wires you see on a sailboat mast. They are critical stabilizers for the cervical spine. They're not extra, they're critical stabilizers. Hey, do me a favor, like, share, comment, subscribe, just because we want other patients to find this information. We want other patients to join us here on a Sunday or a Thursday, simply because we want other CCI patients to be able to ask questions and get answers, because the more varied questions we have, the better this experience is for everybody. Regarding post-PICL, is it true to not notice anything until 3 or 4 months? Yeah, that's generally when we look to see if someone has had an outcome. So realize that for probably half of the patients, they would get some sort of result before that. The other half are probably noticing it around 3 or 4 months. Corinne, decompressing the IJV, do you mean styloidectomy or something else? Yeah, so I do mean styloidectomy is one way to do that. You can get a styloidectomy with a transverse process excision or shaving, C1 transverse process. So yes, it's usually styloidectomy. The strength pill, what are your thoughts about AO technique to correct the atlas? We have lots of CCI and upper cervical patients that do really well with AO or NUCA chiropractic. So I've got a positive view of that. Now, it doesn't work for all of our patients because it's very highly technique dependent on the part of the operator that's doing it to detect the exact vectors that need to be used. So we often will see that sometimes patients are getting the wrong treatment vectors, or maybe the patient just doesn't respond to it at all for whatever reason. Amy, I wish I could have avoided the 2 fusions I had. I feel very lucky and grateful that I finally found an honest neurosurgeon who saved me from quadriplegia. Great, Amy. Blessed beyond, you have patients that come in for PICL who aren't very symptomatic, but on imaging show definite CCI. That's pretty rare because we put up a lot of hoops for patients to jump through, right? You've got to upload all your imaging. You've got to fill out a 12 or 14-page CCI questionnaire. You've got to get on a telemedicine with the doctor and schedule that and review all of that with the doctor. And then you've got to come in for a hands-on physical exam. So if you add all that together, the likelihood that we're going to get someone who isn't very symptomatic is very small, because there's just no incentive for someone who doesn't have symptoms to want to jump through all of those different hoops that we put together. And one of the hoops oftentimes is they don't have the right imaging, right? And then they have to go out and get specialized imaging. So because of that, that's going to be unlikely for us to see. How is CCS treated versus CCI? You know, the treatments are very similar in that you're injecting upper cervical structures like facets and nerves. The difference is often that for CCI, you're also injecting those key ligaments, whereas CCS, you're not. So you can think of a CCI treatment as a CCS treatment plus ligaments. So that's a good way to think about it. But because the treatments are very similar, this is why I always talk to patients about, sometimes they're very upset where they get screened for CCI and they don't have it. But what they don't realize is they may have CCS, meaning just craniocervical syndrome, some upper cervical structures that are causing the same type of symptoms as CCI. And in many ways, it's easier to treat CCS than CCI. So it's not a bad thing if you don't have craniocervical instability. If you still have upper cervical symptoms, it's probably craniocervical syndrome or CCS. Andreas, many symptomatic IJV patients have big collaterals. I suspect instability compresses these collateral roots. Any views on this? Yeah, I think all static venous compression in the body results in collaterals. And yes, so I think that we definitely, this is probably the reason why you tend to see intermittent increases in head pressure with neck position, because you can get compression of those collaterals as well. But it's one of the reasons why static IJV compression isn't really a problem, because all compression of veins generates collaterals around the compressed vein. And so this is one of the reasons why I often scratch my head as to why patients get in such a tizzy over the idea that someone said they have a compressed IJV. A, that normally doesn't cause symptoms. Perhaps one of the reasons it doesn't cause symptoms is you get collaterals. So that's why it's a little bit of a head scratcher for me sometimes. Blessed. Are lower hanging tonsils common in people in general, like not even CCI patients? They are. Chiari 0 is very, very common. Chiari 1 is pretty common in asymptomatic patients. In fact, there's now multiple different papers written on the concept of why some Chiari patients have symptoms and some Chiari patients don't have symptoms, meaning if we just took 100 MRIs that show Chiari 0 or Chiari 1, we wouldn't be able to predict which of those people have symptoms and which of those people are living normal lives. So one of the concepts is that you need something else to get symptoms. One of those things we know is probably craniocervical instability. A number of those things without craniocervical instability can be an irritated suboccipital nerve that then causes the rectus capitis posterior minor to get atrophied. And then that atrophy leads to the lack of the ability to open the back door for CSF flow here. So it's Chiari plus something else equals symptoms. And Chiari alone usually doesn't cause symptoms, at least in its 0 and 1 subtypes. And purple, do patients that have more CCI types have a harder time recovering, or is it more to do with the size of the translations? Is it worse to have moderate widespread damage or localized severe damage? We don't see an association, I've looked at this, on specific CCI types and outcome with an EPICL procedure. We don't see an association between the number of CCI types identified and outcome with the EPICL procedure. So it doesn't seem to go down that pathway. Amity rehab, I'll just say Amity rehab. Can SPECT scan help in the diagnosis of CCI? Normally, it is not helpful in the diagnosis of CCI. Greg, can CCI cause inflammation in the legs, making them feel tight, painful, and stiff, making it hard to walk distances? Or is this more of a possible lumbar issue? Thanks. Yeah, Greg, I think the first thing you'd want to do on hearing that as the treating doctor is to rule out that there's not anything going on in the low back or lumbar spine. And you got to be careful because oftentimes the reading radiologist won't read out things like lumbar multifidus atrophy, but that's an important finding for that kind of leg symptom. So you really have to have an expert look at that lumbar MRI. You can't really rely, in my experience, on the reading radiologist's report. Oftentimes the report will say normal, but there can be very severe low back multifidus or stabilizing muscle atrophy, indicating that the level is unstable. Instability pisses off the nerves. That causes difficulty with weakness in the legs and other types of tightness sensations. Lillian Moon, I have CCI and IIH, and I'm running into difficulty getting help to figure out where the outflow issue is, and my team suspects I need a stent to help the pressure before addressing CCI. Where to start? Yeah, again, the concern there, Lillian, is we keep patients safe by trying the least invasive thing that's the most likely to work. So I don't know much about your particular CCI, but in most CCI patients, that would mean getting a CCI type and then injection-based care first, because that's less invasive than a stent. And if that doesn't work, you can always get the stent. But if you reverse that and put the more invasive procedure first, then you're just exposing yourself to more risk without much added benefit. And that's a real problem in the medical care system, right? We tend to see patients who get exposed to only one type of specialist. That type of specialist only does one thing, let's say put a stent in, and therefore that's all that's offered when there are less invasive options that are available. So that would be the concern. Vera, when you would say it's okay to take NSAIDs, or when would you say it's okay to take NSAIDs for orthopedic pain? I'm not quite sure in what context this question is being asked, but if it's being asked in the context of a regenerative medicine procedure, then you would want to wait at least 3 or 4 weeks for that acute inflammatory response to go away, because you don't want to block that acute inflammatory response with NSAIDs. If it's being asked just in a general context, then the answer is as little as possible. We know now, based on large longitudinal studies and observational studies, that taking NSAIDs seems to be associated with more chronic pain. Why do researchers believe that NSAIDs cause chronic pain? They believe that NSAIDs cause chronic pain because they inhibit a certain type of white blood cell that's involved in resolving pain after inflammation and repair. So basically, NSAIDs are blocking tissue repair, causing chronic pain. So the answer to the second question based on that is as little as physically possible. Now, you're going to pop some NSAIDs every once in a while or take an occasional Tylenol, that's fine. But becoming dependent on either to function is not a good idea based on what we know right now in the peer-reviewed literature. One, is there conservative treatment if I have instability between C1 and C2? Sure, you should always try conservative things like good physical therapy. IPA physical therapy is one I always recommend. You can just go in and type that. You should always try upper cervical chiropractic, AO, NUCA, orthospinology, Blair. And then if that doesn't work, then the next step up from that would be injection-based treatments. The strength pill, if someone has no history of trauma, does he potentially have ligament laxity from bad posture? It's possible to have ligament laxity from bad posture, more degenerative ligament laxity from bad posture. Does bad posture cause CCI? For the most part, no, but it doesn't make it any better. OSA PK. What do you think about Dr. Agnes Stogisa? She doesn't do a PICL procedure. She's never been trained in the PICL procedure, so I'm not quite sure what it is she's offering. She's not approved to do a PICL procedure, so that's the best I can tell you. Was never trained by me to do a PICL procedure. In fact, she came out, saw one or two procedures, then contacted me, and she actually wanted me to teach a course, a weekend course, on how to do a PICL. I thought that was totally medically irresponsible, so I stopped communicating with her after that. So again, never trained by me to perform a PICL. I don't know what she's doing, nor do I believe she's offering a procedure that has much to do with the ePICL procedure we currently offer. Do you think it's a good alternative? No, I don't. If you're trying to get a PICL, the only place to get that is in Colorado. Robert, for anyone fearing PICL, don't. I had my first PICL. It was flawless procedure. The staff's amazing from start to finish. You don't feel a thing, well, until hours after, but it's tolerable. Well, thank you, Robert. Yeah, it is interesting. You know, we now that we're somewhere between 2,500 and 3,000 procedures, we have this procedure well dialed in at this point. It's a well-oiled machine to deliver the procedure. And for the most part, most of our patients have pretty reasonable recoveries. Now, we've learned to mitigate some of the bigger flare-ups by doing the less is more approach. But thank you, Robert, for bringing that up, because we do have a fantastic team in the office. They're constantly working to try to make people feel comfortable. And it's a well-oiled machine. Alex, yeah, I think this is going back to what we were talking about. Just trying to understand the mechanism. I felt the best I felt in 2 years and was holding alignment longer. Now not holding as long and feeling a bit worse, a lot worse than pre-PICL. Yeah, Alex, so I think you're talking about a sort of a donut hole effect. That's a little bit prolonged for the average donut hole effect, but probably that's what you're experiencing. Basically, sounds like you probably had a prolonged inflammatory effect after the PICL, and now you're in that tissue building response, which probably means that your overall PICL recovery response is going to be longer than most. So you probably wouldn't really look at whether or not this is working for you until you get to probably the 6-month mark. Now that's unusual. Most people can make that determination at 3 or 4 months, but some people do have a prolonged recovery and response. So that probably means that you're going to push out that window a bit. So rather than the average 3 or 4 months for taking a look to try to see if this has worked, for you, it's probably going to be more like 6 months. Denise Cope, what area on your website do I find the correction information after PICL? Not sure what you mean, the correction information, maybe the correct post-PICL information. If you get a PICL procedure, we'll send you several times the paperwork. That paperwork includes the PICL instructions. So that'll be what to think about before your procedure. It'll describe what's going on during the procedure. It'll talk about what to do immediately after the procedure. It'll talk about what to do long-term after the procedure. That's not on the website. You've got to sign up for a procedure to get that, but that's available. Kaylee, due to vascular EDS, I have hypoplasia in various veins and arteries with CCI and had deformed first ribs, crushing my thoracic outlet and very hypoplastic scales. With dynamic instability, it's hard to know which problem is fueling the train of events. Yeah, Kaylee, again, the scalenes are critical stabilizers. Now, if they're hypoplastic or smaller than they should be, then that's probably because of lack of neck motion and activity. Can also be due to collar use. But again, they're critical stabilizers, as we discussed before. Blessed, how is CCS treated? Blessed, I think I described that already, so I'll go back to that last answer. The collaterals that are formed are often not substantial enough to handle all of the extra blood flow. By definition, they're substantial enough to handle the extra blood flow. That's the definition of collateral formation. Corinne, I know compression by the transverse process is obvious on imaging, but how do you discern whether pressure resulting from the cranial nerves, or I think you said facet joints? Maybe you're talking about head pressure there. The head pressure, I feel, also comes along the space with a spacey head feeling, heavy body feeling, and sometimes an overall weakness. My life is finally lightened. I'm scheduling with you soon. So I think what you're asking is, how do you know if the head pressure that you're getting is due to swollen facet joints, irritated nerves, a swollen upper cervical bursa? The answer is those symptoms are very similar to the symptoms that you get with IJV compression causing increased head pressure. And the other answer is there isn't an easy way to determine that. You can get some clues, right? You can see, for example, swollen bursa on an MRI. I can tell during physical exam that the upper cervical facet joints are causing headache pain. So those are some clues, but ultimately you have to treat one or the other in order to see if that's causing that head pressure symptom. And since it's a heck of a lot easier to inject those areas rather than to go in and surgically decompress that area around C1, that would be your first choice. It's also much, much less invasive. Robert, is it wise to say that we have to avoid positions and motions where we are unstable, i.e. if right lateral overhang equals avoid doing that motion until treated, or worry that many sleeping positions can pop joints out of place, negate how stem cells work? Yeah, Robert, I think the best possible method to try to stay on the right side of that calculus is really looking at what causes you to be symptomatic. So that's why that whole rehab program is designed around threading the needle, right? What does threading the needle mean? It means you need activity in order to get strong. But if you have too much of the wrong activities, it can cause symptoms. So you got to avoid that. So for example, if you're the kind of patient that you know that every time you sleep in the wrong position, it's hard to control because you're sleeping, you'll wake up and be out of place, then you're probably the kind of patient that wants to sleep with a neck collar after something like a PICL procedure. Or if you know that every time you look to the left and down, that causes a flare-up, then avoid that movement after a PICL procedure, but test it every once in a while to see if it still causes you symptoms. Let's see here. Jeff, not sure if you saw this research, but explains the theory on why eagles may be more symptomatic in connective tissue disorders, novel phenotype of EDS plus CVD with CCI. They found sensitivity to lower pressures, looked at LPs. I think that got cut off, Jeff, but I'll be happy to look at that paper and see what it talks about. Amy, in reference to my upcoming cervical fusion from C2 to C6, likely any recommendations for optimizing my outcome other than normal recovery and safety? Yeah, Amy, that's one for the treating surgeon more than myself. Blessed, how can you tell if the occipital nerves are causing the problem symptoms? Physical exam there is usually pretty good, meaning that if I can reproduce someone's head pressure or head symptoms by putting pressure over the greater occipital nerve, lesser occipital nerve, third occipital nerve, then it's highly likely that that's causing the symptoms. You can also diagnostically block those, i.e. numb those, or just treat those and see if the symptoms go away. Just started. I don't have CCI, but I have compressed IJV at 50% on the right, 100% on the left. Could my issue be something else? I'm fully bedridden and lost. Yeah, I'd need to know a lot more to be able to help you here. But what I can say is that at the end of the day, IJV compression is not uncommon, including completely occluded veins, like one of the studies I showed. So that would be looking with a specialist, but I would say a specialist that's conservative in nature, right? It's hard sometimes to get evaluated by a doctor that does IJV decompression surgery because that's what they tend to want to do. So if they see IJV compression and you've got symptoms, they're not going to look too hard to try to see if the symptoms are coming from the IJV compression. They're just, in my experience, going to do the decompression. So you want to get with someone who doesn't do IJV compression, who can look at that rationally and say, you know what, I think this is probably causing your symptoms or not, but ruling out some of those other common things that cause head pressure, like upper neck facet joints, occipital nerves, that can be done on a hands-on physical exam pretty easily. Tyler, on my pre-screening, it lists Chiari 0 CTE and 0 millimeters Chiari. Noted on my supine MRI, does it mean I have Chiari 0's condition, or is the Chiari is normal? So Chiari 0 is not something that causes symptoms in the vast majority of patients. As I said before, it's really more Chiari plus something else. So if you've got symptoms coming from the Chiari, it's usually Chiari plus CCI, or Chiari plus rectus capitis posterior minor atrophy. So I wouldn't be too concerned about seeing Chiari 0 on an MRI report. Mark, thanks for your extreme dedication, Dr. Centeno. Well, thank you, Mark. If you want to help me there, put a like, comment, share, subscribe, but thank you. Yes, this is my Sunday. I do the same thing on Thursday evenings oftentimes, just trying to get out there and answer patient questions, because at the end of the day, I think it's critical in this community to make sure that good information is put out there, especially because we kind of have the social media echo chamber, and sometimes bad information tends to rise to the top. So thank you so much for recognizing that. Aaron, how does Regen Med help to treat fibrosis in the upper cervical spine as a result of injury? Can a PICL result in calcification of ligaments over time, ligaments becoming too tight, rigid? I don't know what fibrosis in this context means. If what you mean is you've lost lots of neck range of motion, that's regrettable, right? Because now we have two problems. One problem is loss of neck range of motion. The other problem could be craniocervical instability. So I don't know what that means in this context. But usually PICLs obviously wouldn't cause calcification of the ligaments. And ligaments being tight are a good thing. That's what we want, is tight ligaments. So I think there's some confusion there. Okay, guys, so we're coming to the final bit here because I'm approaching an hour under cover Sentinel. For a patient with HEDS, multiple whiplashes with neurologic symptoms that escalated in the last 18 months, but never went to a chiropractor, would you recommend going to Dr. Rosa before seeing you? Sure. As I've always said, Dr. Rosa provides an incredible amount of information to the patient, to myself, etc. The only time that I would say just be cautious there is if you're resource constrained. Some patients are very resource constrained, and in which case, then you want to take the sort of the path of least resistance. That's the lowest cost to try to get to a diagnosis. So that's the only time where I might recommend someone, let's say, just pursue a DMX to see if they've got CCI. But if resources aren't the rate limiting step, then absolutely. Andreas, can lymphatic vessels also be disturbed by CCI and reduce lymphatic clearance, perhaps through direct vessel compression? That certainly could be a good theory. Okay, guys, well, I got more questions than I can answer. We're just past an hour here, so I'm going to start wrapping this up. Thank you for everyone for being here on a Sunday morning. Thanks for asking all these great questions, because that's how others learn. Do me a favor, give me a like, comment, share, subscribe as you leave, because that's how other patients find this, and that's how you pay it forward in the CCI community. But thanks for spending a Sunday morning with me, answering or having me answer these questions and giving me the opportunity to do that. I'm grateful for that. And you all have a wonderful Sunday with your families, and then obviously have a great week. I'll be back here next week, either on Thursday or Sunday, depending on family commitments. Thanks so much.